area. This usually is important both in your exams and in your clinical rotation. A, P, T, M for easily memorizing the fourth major location. Along with that, always remember that the murmur of the atrial septal defect occurs at the left upper sternal border. That is the area of the pulmonic. Like at the area of the pulmonic, you will hear the murmur of atrial septal defect. And moreover, the murmur of the ventricular septal defect occurs at the tricuspid area. That is the fourth left intercostal space. And the murmur of the hypertrophic cardiomyopathy is also heard best at left lower sternal border, like you can say the area between the pulmonic and the tricuspid, a little above the fourth intercostal space, like little above the tricuspid area, you will hear that the murmur of that hypertrophic cardiomyopathy. Now, I will give you an example that how to find out the murmur simply based on the few clue in the description. So here is an example. That is a 78-year-old male presents with the complaining of the dyspnea on insertion and the exertional angina for the past 3 months. On exam, you note a 2 by 4 systolic murmur. Now, please focus on the area that I have highlighted. And the status murmurs are most prominent at the apical area. Now, which of the following is the correct murmur? Now, first of all, let's simplify this. Basically, you need to look for the few things. One is the which type of the murmur. Either is it systolic or diastolic. Here, they simply give the systolic one. Next, you have to look for the location where it is occurring. Now, in that case, it's apical area. Now, if one knows that these two pieces of location, you can solve the murmur without any difficulty, and even you don't need to listen to the audio file as an exam. The time is very limited. So you have to diagnose the scenario even from these details. Can you please give me some time? Sorry. All right. Now, in this case, this says that the systolic murmur and second is the apical area. So you know that it's the mitral area and the apex, mitral area lies at the apex. So must be the murmur that is related to the mitral wall. Now, next important thing is that whether it's the mitral stenosis or regurgitation. And that is where the systolic and diastolic part comes into the play. So now you have to ask yourself that what happens at the wall during the systole versus diastole. So taking about the mitral wall in the parts. As we know that during the diastole, blood gonna flows from left atrium to left ventricle and left ventricle fills during diastole. However, in the systole, blood is ejected out of left ventricle and it also has the potential of going back across the mitral valve. Like in diastolic, when the blood is ejecting out of the left ventricle, some of the blood is also regurgitating back. So now you can understand that it's in systole and when which is the phenomena occurring, it's regurgitation. So from the location, it's mitral, and from the clue that they have given the systole, and we know that in systole, it's going to be regurgitate. Although the blood from the left ventricle is regurgitating back into the left atrium. So the only time the murmur occurs on during the systole is during mitral regurgitation. So that is the reason that during systole, mitral regurgitation and the systolic murmur occurs at the apical area, not the diastolic. Now I will explain you the diastolic concept too. If it has the mitral stenosis, all right, then it would have to be a diastolic murmur. Why? It's not be a mitral stenosis. Why? Because the only time you have the mitral stenosis is when the blood flows across the mitral wall. And when the blood flow across the mitral wall is there when the left atrium is trying to throw the blood into the ventricle. And actually, it's the filling phase of left ventricle, and you know that the filling phase of left ventricle all occur during the diastole. Now you understand that how the stenosis all case of mitral scenario occurs during the diastolic phase. However, the regurgitation murmur of the mitral occurs during the systolic phase. So simple trick is first recognize which area is mentioned and then rule out that what happened at that area during the systole and diastole. In all right, in stenosis, we have the filling problem. And filling is which phase? Diastole. So we can never ever take mitral stenosis for the diastole. So only what we have left behind, that is the regurgitation, and simply without even listening to the voice note and each in the audio file, you can gonna be picking the option of mitral regurgitation. All right, do you understand that concept?
Yes.
Yes.
Perfect. Now, if you know that these slide, trust me that you gonna make 60% of your diagnosis. So I suggest you that learn this slide by heart. Like the all the cases of aortic stenosis and pulmonic stenosis goes for systolic phase. All right, we memorize it via the trick. Like aortic and pulmonic stenosis occurs during the systolic, so we can't take the tricuspid and mitral stenosis during the systoles. All right, if aortic stenosis and pulmonic stenosis is for systolic phase, then the tricuspid stenosis and mitral stenosis is for diastolic phase. Another one is if the stenosis of tricuspid and mitral is during diastole, then what we left behind is regurgitation. So tricuspid regurgitation and mitral regurgitation is during systolic phase, and aortic regurgitation and pulmonic regurgitation is for diastolic phase. So it's a simple technique that if one valve is of stenosis in one phase, that is systolic, then it's another scenario, that is the regurgitation must be in opposite, that is the diastolic. So if you know this slide, and when the aortic stenosis occur, this is and you know that in diastolic actually which murmur you gonna be getting, then trust me that you will easily diagnosing your scenario. Now, moving towards our some of an important murmurs. First of all is the right-sided murmur. Now, what make the murmur louder and the softer? During inspiration, it is the right-sided murmur which get louder. I have made a trick like rinspiration. Rinspiration R for right and inspiration let loud on inspiration, that is right side, and expiration is for the left-sided murmur, and the left-sided murmur got louder during expiration. Now the test writer is going to trick you and give you the 10 line vignette and would say that the murmur increase on inspiration. From that point, you have to rule out, oh, it's right-sided murmur. Why? Because they simply say you that it increases on the inspiration. And then you have to go for the tricuspid. If now you know that on the right side we have two valves, it's tricuspid and pulmonic. So automatically we have ruled out the aortic and mitral. Only two options are left. Now, if they have given you the left upper sternal border, it's gonna be the tricuspid. And if they mention the left upper sternal border, it's the pulmonic. And then longwise you will apply the rule of that systolic and the diastolic, and you will gonna be easily diagnosing the whole scenario. Now, I will give you an example that during the inspiration, blood flow through the right side of the heart increases. So the murmur of right side, like tricuspid regurgitation and stenosis, pulmonic regurgitation and stenosis, all increases during the inspiration. For example, a murmur that is best heard on the left lower sternal border during the systolic phase. All right, first of all, I have given you the location, that is the left lower sternal border. The left lower sternal border means you have to go for tricuspid area. Now, the murmur intensity increases on inspiration, ultimately rules that it is the right side pathology. So, as from the location, if the lower sternal border mean the tricuspid area, and secondly the systolic phase, and you know that during the systole it's gonna be the tricuspid regurgitation, as I have mentioned above. So, uh, inspiration is the one buzzword, second buzzword is the location, and third buzzword is during which phase. Next, moving towards the Valsalva maneuver affects hemodynamic. And trust me, if you know that maneuver, you are getting a lot of your UWorld questions right, because that Valsalva maneuver is going to repeat in a lot of the concepts. Now, I will tell you that how Valsalva maneuver
I
affects.
have a question. I'm sorry. You can repeat the previous slide. Just I need to confirm. During inspiration, mainly that is means the murmur from the tricuspid area.
All right.
Okay,
Here
thank you. I
I
appreciate it.
here I
No,
have
the next one. Okay, thank you.
First of all, I will clear you this. I have mentioned that in the systolic phase, there is the tricuspid regurgitation. All right?
Yes.
Tricuspid regurgitation. And the second one is pulmonic stenosis. We have to rule out that there is the right side. So we have only two valves discussing. Its number first is the pulmonic stenosis, and the second is tricuspid regurgitation. Now that I have told you that second important thing is the location, all right? And I have given you that the murmur is best heard on the left lower sternal border. Its mean is tricuspid. And then I have given you a buzzword that it's gonna increase on systolic phase. Two buzzwords, systolic phase, left lower sternal border, then ultimately it goes for tricuspid regurgitation, because the tricuspid stenosis gonna be heard on the diastolic phase. Have your point cleared?
Yes, thank you. I appreciate it. Thank you.
Perfect. Now, how Valsalva maneuver affect hemodynamic? As you know that our vein, that is the inferior vena cava, brings the blood up to your heart to the right side of the part. Now imagine when you take a deep breath, then your diaphragm gets pushed down and you tighten your stomach muscle. What do you think will happen to the pressure inside your abdomen during the strain phase? All right, you can simply
Increase.
think that diaphragm is down and your
Increase.
stomach muscles are tightened, and ultimately your abdominal pressure increases. All right. Now the question is what that increased abdominal pressure will do that to the vein. What it will do? It will compress your veins. Now the compression of inferior vena cava reduces the amount of blood that can return back to the heart. So what can we say about the Valsalva in preload? All right, it's strain phase and it's increase intrathoracic pressure and it have compressed our inferior vena cava. Although then it means that no blood is coming back to the right atrium to ultimately we have reduced preload. So it's all occurred during the strain phase of maneuver. although they will trick you with the either strain phase and release phase. So most of the time the students when see that they maneuver, then they actually click, oh, it's the preload that gonna decreases. It ultimately goes wrong if they have mentioned the release phase, because the scenario is different in the release phase. What happens in the release phase? There is the sudden drop in intrathoracic pressure in the release phase, which releases the compressed vein and results in the increased venous return. So, have you know that there are totally two different cases. In venous strain phase, there is decreased venous return, there is decreased preload, which results in decreased stroke volume, decrease in the mean arterial pressure, although no cardiac output and no blood pressure decreases, which results in decreased pulse pressure. And as we know that whenever our blood pressure decreases, there is a reflex tachycardia. That is the reason the heart rate is increased. All right. Now there is the release phase. Release phase, as I have mentioned, that compression on the vein has now been released. So now the blood can easily move through these veins, which results in increased venous return and increased preload. So you have to memorize these two cases, strain phase and release phase, and their difference on your fingertips. Now, I will explain you that how the squatting affects the hemodynamic. First, I have explained that how the maneuver affect hemodynamic. Moreover, you will also know that whenever you from the sit or from sitting position, you sudden I would say that stand, then there is also the sudden decrease in the preload. Moreover, in the passive leg raise, there is also increased preload. And another is then squatting. Now, what happened in squatting? During squatting, you are alternatively moving up and down. So it's easier for the blood in the veins in your legs to get to your heart, which results in increased preload. All right. So whenever it's normally a practice in our hospital condition that whenever their patient or person comes who feel dizzy, nausea, or even weakness due to the orthostatic hypotension, then sudden applying the squatting will make the patient feels better. Now I have told you that how it increases the preload. Moreover, squatting also increases the afterload. That when you are squatting, actually you are squeezing a lot of the muscles in your leg and at the crease of your femoral arteries. So this increases there's compression of the muscles and that arteries ultimately increases the afterload. That is the really testable concept of the step one. Why? Because of the reason of the tetralogy of the fallet. Because in the tetralogy of the fallet, if the patient is applied directly the squatting, then the cyanotic condition improves. How now I will explain the whole that concept. That whenever you squat, it will increase the afterload. I have explained how it increases the afterload. Then ultimately the increase in the left ventricular blood. Now, when the left ventricle blood increases, and in tetralogy of Fallot, we also have a ventricular septal defect. So all the blood from the left ventricle now moved into the right ventricle through ventricular septal defect. So now I think that more blood in the right ventricle, more blood goes into the pulmonary artery, ultimately into the lungs, and more blood get oxygenated, and thus the oxygenated blood is then supplied to the left atrium, left ventricle, and into the body, and the signs of the cyanotic gets relieved. Now you understand that how the squatting improves tetralogy of Fallot?
Yes.
Got
Got
it.
it.
Yes.
Perfect. Now, let's move towards the other slide and what makes your murmur louder and softer? This is a very, very high yield concept. You get a lot of the questions, so please concentrate on this slide. So whenever you increases the preload, you are pushing increased blood flow back to the heart. All right. So more blood now flows toward your valve that are either stenotic or regurgitated. So ultimately, the murmur becomes louder because the more blood is going to flow over so on. Example, if you usually have the mitral stenosis, the more blood flows through the mitral wall. So murmur is going to be the louder because the more blood is going to flow through already stenotic wall. All right. So, there is, but all the cases of stenotic and regurgitation, whenever the preload increases, all the murmurs get louder. However, the exception of hypertrophic obstructive cardiomyopathy and the mitral valve prolapse is there, and this is very high yield concept. So, I'm gonna explain you that when you have the hypertrophic obstructive cardiomyopathy, your heart become hypertrophied and the septum bulges and blocks the outflow tract. So normally, more blood when flows in the heart, it will pushes the septum back its to in central or normal physiologic position. So in hypertrophic obstructive cardiomyopathy, if you envision this diagram in your head that whenever the more blood, it means more pressure. More pressure across the septum pushes the septum back into its middle and normal position and reopens the outflow tract. So anytime if you increase the preload, either by you are doing squatting or the leg raising, more blood is gonna flow through the heart. And anytime the more blood flow into the heart, then the murmurs of the hookah and the mitral valve prolapse get better, or you can say that it's softer because that obstruction is now relieved. But all the murmurs of stenotic and regurgitation gets louder. Now you can ask that I have explained the hookam that you can say that that is the septum. So if there is the increased blood flow, the increased pressure gets the pushes the septum into its normal physiologic position. Low blood flow and ultimately this whole outflow tract is obstructed. Mitral valve prolapse, although it's not very high yield, but I will explain you the concept that in case of the mitral valve prolapse, whenever there is the increased blood in the heart, it will displaces the mitral valve leaflets back into their normal position. So that is the reason their leaflets due to increased blood get back to the normal position that the murmur gets softer. All right. So the squatting or the leg raising ultimately result or increase preload all results in increase the murmurs of all other condition, but hookam and mitral valve prolapse get softer. Now jump towards the other side of the slide. If you are gonna decrease preload, you get the softer murmur across all the valves. And it's same exact reason, right? That less blood is going back to the heart, less blood is flow across the stenotic and regurgitating valve, so the murmur gets better and the softer. And again, exception is the hookam and the mitral valve prolapse. The reason why the less blood flow in heart, less blood is there to push the septum away, so the more bulging of the septum results in obstruction of the outflow tract and the hookam and the mitral valve prolapse both gonna worse. Next is our increase
I'm
afterload.
sorry, excuse me. So that means that the decreased preload and like a hypertrophic cardiomyopathy, it would actually make it louder then, right? Like it would make the murmur louder?
Yeah.
Okay. Thank you.
So moving towards the afterload, afterload is the pressure against the which your heart has to pump. All right. So whenever increased afterload mean increased pressure is exerted upon the left ventricle as it tries to eject the blood out of the heart. So you can increase the afterload by doing this exercise that is known as the hand gripping. So whenever you are increasing the afterload, you get all louder regurgitating murmurs. Do you know there any one of you reason that why when you increase the afterload, regurgitating murmur get louder? Don't worry, I will explain that concept. Now that you know that if the heart has to pump against the greater pressure, that is increase after load, then mean that there are more pressure for forcing the blood backward. Means the blood is not easily going forward because there is the resistance. So there will be the more blood in left ventricle and more will be it going in a backward direction instead of going into the forward direction. Normally the blood is going to pump out of the heart, but if it's pumping against a great pressure, then you have to think that the more pressure is going to be exerted upon the heart, which is going to try to force the blood backward. And it exactly what the regurgitating murmur is, that blood flow accidentally backward in the wrong direction, back over the wall. So whenever you are increasing the afterload, forward flow is decreased, backward flow is increased. That's the reason the regurgitating murmur gets louder. All right. Now, when you get the increase afterload, all right, it means that the blood not easily moving out of the left ventricle into the aorta and more blood is there in the left ventricle, so you can get softer hook'em because softer mitral valve prolapse too, and both murmurs better because more blood is there to return the heart normally in its physiologic section, that is the relieving the obstructive outflow tract, because more blood, more pressure is there, and that is the reason increase hand gripping and increasing the afterload also makes the softer hook'em, and moreover regurgitant, all the regurgitation murmurs get louder in the case of increase in the afterload. However, I have mentioned that's one concept to decrease afterload, although it's not very the important one. But I have mentioned whenever you give a drug that is amyl nitrite, it's gonna decreasing your afterload, and whenever the afterload is decreased, you get the louder hook'em and the mitral valve prolapse. It again, it's the reason that decrease afterload, less blood, and more obstruction. Now, I have given scenario just to master your concept. There is a patient who present with the evaluation of the dizziness and occasional palpitation. He has no medical history and takes no medication on cardiac auscultation, a systolic. Now, please, first of all, first one buzzword is athlete. All right. Second buzzword is the systolic crescendo, decrescendo murmur. All right. Third buzzword is they have mentioned that it's the left lower sternal border, and the murmur decreases in intensity when he squats. Mean whenever he's squatting, he is increasing the afterload, and the murmur is gonna decrease and increase with the standing. All right, whenever you stand, the preload is decreases, mean the blood flow in the heart is decreases. Then squatting gonna decreasing the murmur, and decrease preload, that is standing, increasing the murmur. And highlight the buzzword. Which of the following best explain the changes in the murmur intensity with squatting in this condition? First of all, I have to diagnose that it's the athlete. Second buzzword is systolic crescendo murmur, and third buzzword is the left lower sternal border. Then it's the case of hypertrophic obstructive cardiomyopathy, as the increase after loads gonna decreasing the murmur too. Now, can you give me that what would be the most possible option? Increase afterload decreases the murmur by reducing the myocardial contractility. Increase preload reduces the left ventricular outflow tract obstruction. Decrease heart rate, increase ventricle filling time, and increase systemic vascular resistance exacerbate mitral regurgitation. If anyone of you knows the answer, please unmute the mic.
B.
B.
Why the reason?
B.
Increase the
because the
preload.
left ventricle volume will increase because there'll be more blood in the left ventricle, so the septum will be
Perfect, perfect. It's actually increased preload reduces the left ventricle outflow tract obstruction. So here I have, as already told you, that in the step one, they will never ever give you the diagnosis. You first have to diagnose and then you have to master the concept and what's the basic that line. Like in the case of the hypertrophic obstructive cardiomyopathy, if you can diagnose that condition, then you will gonna be answered then that which maneuver is gonna increasing its murmur and which maneuver is gonna decreasing the maneuver. Hypertrophic obstructive myopathy is caused by asymmetric septal hypertrophy and dynamic left ventricle outflow tract obstruction. Now, its murmur is systolic crescendo decrescendo that is best heard at the left lower sternal border. It increases with the Valsalva and the standing, and it decreases with the squatting or leg raise. Now, I have mentioned some high yield association of all of the murmurs that you get some pet buzzwords on your weeknet, and if you know these high yield points, trust me, you are going to pick that scenario very easily because there are always must 2 to 3 MCQs of the murmurs on every form. Most of the time it's aortic stenosis. I have seen that 90% of the student must get either the case of the bicuspid aortic wall or aortic stenosis. Now, what important thing they will gonna be mentioning in your like scenario? First of all, it's the crescendo decrescendo murmur. Most important is if they give you the 89 or 90 without even thinking, go for the aortic stenosis. Then its mnemonic is said that the patient feels syncope, angina, and dyspnea. Now, due to the old age, the valve get calcified. That results in a stenosis of the valve, and you get the pulsus paradoxus. That is the weak and the feeble pulse that you felt best heard at the base and it radiates to the carotid. High yield buzzwords on the Wicknet is that a 70-year-old age, first of all, most important is the age, present with dyspnea after taking the few steps and have the systolic weak murmur. You see that is the systolic, and second, you have to see the location. In that case, it's the base of the heart and it's radiating to the carotid. Now you can very easily answer that it's the scenario of aortic stenosis. Moving towards the mitral regurgitation is a hollow systolic murmur. Most of the time, they will always give you the history of the rheumatic fever because mitral regurgitation 90% of the time is associated with the rheumatic fever, and the mitral regurgitation radiates to the axilla. Next is the tricuspid regurgitation. Tricuspid regurgitation is the holosystolic murmur, history of the IV drug abuse, and the cause of the tricuspid regurgitation is pulmonary hypertension and core pulmonary. I have seen on the MBME that they will give you an example like they will give you a patient who either has the primary pulmonary hypertension or either will give you the patient of the right-sided core pulmonary. Now, then they will give you both option that what it happens in, although you can say that right pulmonary and the pulmonary hypertension, it's only the right-sided pathology, but they will mention both like tricuspid regurgitation or pulmonary regurgitation. Always remember in case of pulmonary hypertension and core pulmonary, it's gonna be tricuspid regurgitation. Although the mechanism and the reason is still unknown, but never ever go for the option of pulmonary regurgitation. It's the tricuspid regurgitation. And moreover, any the patient with viral hepatitis, IV drug abuse, always go for tricuspid regurgitation. Why tricuspid regurgitation? Because from the liver after the inferior vena cava, the first of the blood is going all into the right atrium, and the first valve it gonna met is a tricuspid. So that is the reason that IV drug abuse most of the time results in the tricuspid regurgitation. Next, moving towards the mitral stenosis, it's the opening snap and it's the history of the rheumatic fever in either the childhood or the 20 years. But always remember, if there is the acute history of rheumatic fever, always go for either the mitral regurgitation and then for aortic regurgitation. In acute history, patient never ever present with stenotic condition. It's the long time history. They will mention that in the childhood, the patient get like staph aureus infection or any upper respiratory tract infection, or either the 20-year back he have the history of rheumatic fever. Then you have to go for stenosis because stenosis never occurs in an early phase. And although when they, or you can say that mitral stenosis, now the blood have difficulty to move from the left atrium to the left ventricle, so ultimately it results in the left atrial dilation. So you know that when a left atrial dilation, right back the left atrium, we have the esophagus, and we also have the vagus nerve. So it results in the Ortner syndrome, in which we have the esophagus dysphagia and recurrent laryngeal nerve abnormality, all that. Moreover, left atrium dilate, then all the blood is now pooling back into the lung, which results in the pulmonary congestion. And moreover, whenever left atrial dilates, there will be the you can say that an ectopic foci gets formed in the pulmonary vein, which results in atrial fibrillation. That all are the complication of mitral stenosis. Next is the mitral valve prolapse. Mitral valve prolapse is not very important, but I have mentioned it. It's the mid-systolic click, and it's associated with either the young woman and him who has the psychiatric history. And most often of the time, it is caused by myxomatous valve disease. Uh, Wait, I have missed one slide. Now I will explain you the atrial fibrillation and the atrial flutter. Give me some time. And you know that in the case of the atrial fibrillation, the whole rhythm is disturbed. You have irregular P wave. Why? Because there is now not the hold of SNO. There is all the hold of abnormal ectopic foci that happen in the ostium of the pulmonary vein. That results in the abnormal P wave, and you get regularly irregular you can say that rhythm. Now you can say that here two QRS complex, there are not the same distance, that the whole rhythm is disturbed. However, in atrial flutter, you can say that two peak R waves are an equal interval. That is the difference. You have to differentiate from the atrial fibrillation from the atrial flutter. First important point is that its rhythm is normal. However, in atrial fibrillation, its rhythm is abnormal. Now, the common risk factors of the atrial fibrillation is either the hypertension and the coronary artery disease, and most predisposed to the thromboembolic event, particularly the stroke. Now, in whenever we will be covering the CNS and in the stroke patient, they must ever give the history of the atrial fibrillation. They will not mention the buzzword atrial fibrillation. You have to diagnose first that it's atrial fibrillation. Then you have to know that yes, we know that it's a complication, that the embolus dislodge from the atrium and it's move upward into the internal carotid, and it's blocked either in the anterior carotid artery, posterior carotid artery, whatever we will explain in the CNS. But it's a very complication. That is the reason in the patient of atrial fibrillation, we will always go for the anticoagulation, that is heparin and the warfarin. However, atrial flutter, I have never seen any question of the atrial flutter on MBMEs, but I have mentioned it just to diagnose these two conditions. It's actually the sawtooth pattern. Here you can say that it's a sawtooth pattern, and atrial flutter is due to the consecutive atrial depolarization wave causing sawtooth appearance of P wave. And why? It's actually arrhythmogenic activity from re-entry circuit around the tricuspid annulus in the right atrium. Now you know that normally there is a path from SA node to AV node. But in case of atrial flutter, we have another re-entry circuit around the tricuspid annulus, which results in that successive or additional, you can say that P waves, and we can get that sawtooth pattern on the ECG. A whole QRS is disturbed in atrial fibrillation. However, in atrial flutter, it's not disturbed. And next, I have mentioned, although today I have only mentioned only the atrial fibrillation and atrial flutter, the only reason is that if I cover all the ECGs by today, you will end with like mixing of all these ECG. So on each my session, I will add two ECGs so that you can perfectly master the concept and will be able to differentiate all the ECGs, because ECGs are very, very high and you must get the question of the ECG on your form. Now it's a very high yield point and you will get the question from these points from both in MBME and in your reality. Always remember there are two cases. In its first is atrial fibrillation that is recurrent, and second is the permanent. If there is the recurrent atrial fibrillation, then always choose the option yet in treatment you have to do the radio frequency ablation of pulmonary vein ostium. However, if scenario gives you the permanent atrial fibrillation, and if you gonna choose the option of the ablation of pulmonary vein ostium, it's gonna be wrong, because in permanent atrial fibrillation, actually you have to slow the AV node. All right, that is the reason you gonna be do the ablation of AV node. However, it's atrial flutter. Mistakenly, I have written the fibrillation in atrial flutter. There is the radio frequency ablation of tricuspid annulus, and I have explained you why it's tricuspid annulus, because it's the abnormal re-entry pathway. And the most common site of the thrombus formation in atrial fibrillation is left atrial appendages. That's all for our today. However, some of the students mentioned me that they are getting the trouble or in the concept of cardiac output and venous return curve. Let me briefly explain you that concept. Although it's not like that much tricky, but still I will go you. Mm. That there are two conditions. First is the heart failure. You will, whenever you will read the first aid, they have given the two conditions. You can briefly explain, understand it. First, only get the concept. One is the heart failure, and other is the acute hemorrhage. Whenever there is acute hemorrhage, like you get a road traffic accident and your femoral get fracture, which results in a severe acute hemorrhage. Now, in the heart failure, you know that patient myocardium contractility is lost. So what we have to give either catecholamines or dobutamines or milrinone. What it do is that it acts on your beta 1 and beta 2 receptors on the heart, and it will increase the contractility, because we have the problem heart failure in contractility. So all it would do is it increase the contractility and increase the inotropic effect. When although when contractility increases, we have increased cardiac output. So whenever you can see the graph on the book, you can see that from the black point that the graph of the cardiac output increase when you give the catecholamine, dopamine, and the milrinone. And that is the reason, because these all are positive inotropic agents, and it increases the contractility, which results in increased cardiac output. Now, second important condition is severe acute hemorrhage. Now, whenever the patient of severe acute hemorrhage came in the emergency, you first have to maintain its systemic circulatory volume. Reason because he already has lost a lot of the blood. So what you can do is give the patient rapid fluid infusion to the which results in obviously when you give the more amount of fluid, its circulatory volume increases, which increases the venous return. Along with that, when venous return is increased, mean we have one problem, that is the fluid loss gonna be solved. That now we have to move on to another. Moreover, along with giving the fluid, we will give this patient vasopressors that in the book they have been given the sympathomimetics. Actually, sympathomimetics are vasopressor. What they do is that they increase the sympathetic tone. Now you know that whenever sympathetic tone on the heart is increases, then the contractility increases and it ultimately increases the cardiac output. So what we need in basically acute hemorrhage, your brain, your vital organs, your brain, like your heart, your kidneys need more blood flow. So we are giving the fluid infusion and giving the cardiac output vasopressor. We are gonna solving these two pathologies. They have only just confused you with the graph, but only you have to master these two concepts. Don't go for the graph. If you know this basic concept, you will gonna be solving all the questions of UWorld. All right, that's all for today. Hope so you get that concept clearly. Although that is, I would say that CVS is a bit tricky, and you have to master and practice repeatedly in order to be get pro in that field. So if you have any queries, you could ask, or on the other, we can like sum the discussion for today. I think there is no questions, so here we are.
I'm sorry. Can I just, if it would be possible, could I see the slide again with the practice question that we saw about hypertrophic cardiomyopathy?
All right, no problem. You will get that all these slides in the group too. But here I am again sharing it.
Thank
Good
you.
evening. Good
If you
evening.
still have the problem, I can explain it to you.
Okay, good evening. Please, if the session was recorded, can we get a recording of the session?
Yeah, sure.
Uh,
You can get the
yes.
recording of the session and also the PDF slides. They will be shared in the group. Don't worry about that.
Okay, thank you.
You're welcome. Okay, that's all for today. Thank you, Dr. Alina, for the session. We will now be ending the session. If students have any questions, they can simply drop the questions in the group. Thank you, everyone, for joining in.
Thank you so much.
Thank you.
Thank you.